Dear Harry Chairman and our distinguished colleagues and ladies and gentlemen, I reported this future perspective in ACS. In China, incident the 87.6 per 100,000 adults, men or women. Mortality the 6.3% for STEMI, and 3 and to 7% of the non-STEMI, rural or urban. This is a phenotype to the change, the non-classic phenotype, Manaka, the plaque, rupture, erosion, the spasm, SCAD, microvascular dysfunction, the embolism. The SCAD, intimate tear, and intramural, the hematoma, and compressed the true lumen induce the acute myocardial infarction. The inoca, the microvascular dysfunction, the vasospasm. We now to change this to classification. So guidelines recommend the mechanism-based management, type 1 myocardial infarction, atherosclerotic myocardial infarction. Underline most STEMI, non-STEMI, and some monocar and SCAD. Use antiplatelet plus reperfusion. Type 2 myocardial infarction occurs some of the classic ACS, the monocar or SCAD, and treat underlying cause. This is a new definition from the ischemic heart disease to the myocardial ischemic syndrome, from chronic, stable to non-acute, acute classification. Redefining the ACS, the multi-mechanistic acute ischemic event, from ischemia managed to the atherosclerosis management. The License Commission 2025 from ischemia to the atheroma. I think the time still is the muscle. The total FMC to device time is the call. Each 30 minutes the delay in the reperfusion increase 1 year mortality by 7.5%. Non-STEMI early invasive approach, the guide by risk stratification. STEMI direct to the PCI, door to balloon time only less than 90 minutes. Inter-hospital transport, door in, door out, less than 30 or 45 minutes. FMC2 device less 120 minutes. PCR daily anticipate the immediately fibrinolysis in the early 2 to 24 hour invasive surgery. We think it's ideal to per hospital use one pack of the medicine in the China. But now we want to transfer the one bolus injection to a faster to control the antiplatelet. So this China experience the National Chest Pain Center program have treated over 4 million AMI patients in 5 years. STEMI mortality reduced from 10.1% to 3.3%. This is Beijing Anzhen Hospital, our hospital. The 40 years young ER doctor to got the AMI. This doctor to in our hospital every year we perform PCI about 35,000 cases. So this young doctor, ER young doctor, to in holiday 1 day perform the 7 cases, the emergency PCI. So we are put 2 students with that young doctor. So the China early CHD, the acute myocardial in our hospital. But 29, the young woman, the island students, the have the acute myocardial infarction 2 times. But transport our hospital, we found this spontaneous coronary intramural hematoma. We are published this patient the treatment, the results give a JACC intervention published. So the China, the women and the young man, ACS more and more occur. The pre-hospital management, the standardized early medication pack enable rapidly the guideline therapy and the first contact. Integrated care pathway, the seamless EMS hospital coordination, the minimize the daily improve outcome. Digital driven precision, the digital ECG and early activation accelerate the diagnosis and treatment. Protocol-based risk, the reduction, the early dual antiplatelet plus anticoagulant, the therapy reduce events. This the pharmacological the therapy the suggestion, the personalization risk adapt anti-thrombotic therapy with early the escalation and the balance ischemia and the bleeding. Intensification, the early aggressive lipid lower with the PCSK9 inhibit, accelerate the LAL, the cholesterol control and the outcome improvement. Precision, the EF guided beta block use, benefit limited to the mild reduce the EF 40 to 49%. Innovation, anti-inflammatory and novel anti-thrombotic the agent, like just said, the colchicine and IL-1BT inhibit show the promise, but need further validation. The type of invasive surgery, the study stemming clinical evidence, pharmacoinvasive surgery, lysis transfer PCI over or equal 2 hours, reduce the mortality by 21% with fibrinolysis alone. In elderly ACS patient, mean age the 82.6. This article very little. So early invasive surgery lower recurrent myocardial infarction by 22% and the vascularization by the 87%, but increased bleeding. This our the hospital, our team use 2021 to first use domestic robotic PCI for to this confirm its safety and reliability, and to this year to publish the first RCT results to confirm this safety and efficacy in the complex coronary lesion. The reperfusion surgery, the tech evolution, imaging, robotics, and AI will enable safe, more precise, and individualized the PCI. Imaging guidance, the broad iris OCT use will drive mechanism and base intervention for the complex lesion. Robotics expansion, robotic and remote PCI will increase access and safety for the complex case. Flexible decision, the early risk assessment and flexible time will improve myocardial salvage and outcome. The special population, the individualization and the risk-based strategy will guide ACS management in the elderly, frail, and high-risk patient. CKD focus the guideline therapy and revascularization and should continue despite advanced renal dysfunction. Geriatric the balance invasive strategy offer limited survival benefit in the elderly and increases bleeding risk. Heart failure prevention, the early detection and second prevention and post-ACS heart failure are the key priority. Urgent intervention, still rapid recognition and treatment on the mechanical and valve complication improve outcome. So transition from acute care to the long-term management in the China, we are continue ongoing this study active. To after discharge, medication, education, and follow-up and referral, we are to a logical suggestion the patient receive follow-up. Long-term management, individualization, the biomarker-based risk stratification enable more precise therapy, integration, coordination, alternative transition, and early multidisciplinary follow-up reduce the early events. Inflammation, the targets, the caution, and other anti-inflammatory therapy are the reshape second prevention. Rehabilitation the first, digital health. We hope the first enter the patient family maybe is AI robot. This robot first time to diagnosis and first to treatment in the patient family. That family to the many house in the China house run. At last, dead. This kind of family easy to ACS. This kind of patient. So we think that we are, in the future perspective, ACS the cath lab, we are changing to AI doctor to deal with this PCI. No light. This automobile to perform PCI. I think maybe 5 years or 10 years, maybe a young doctor, you can do this kind of cath lab. The doctor 郭勇, Chengdu province have this Panda robotic. This case to show this 26 EF the case. So this our hospital back CT, hepatic CT are very poor. This LG very serious calcification. The RCA subtotal very calcification. We want to use to China native impeller and shockwave. So use this case. So we first to impeller 5.0 and support this patient and put a 2 stent in RCA. Very difficult. We use 5-in-6 guiding catheter. This RCA results. We open the RCA. We use the shock wave about 80 times. Maybe last time we get a success. This ultrasound show that fracture the very calcification. We put a stent with complete revascularization. So 1 week, this patient, the EF to recover 37%. And this SPECT CT improvement. And 1 month, this patient EF reach 51%. This is my team. This man to 2 times the infection, anterior and inferior infection. That hospital to put 4 stent for LAD and RCA, and all of us stent occlusion. To put the IBP transfer for the Beijing Anzhen Hospital, our hospital. We found EF only 15, but thrombus in the left ventricle. We are put the ECMO plus the IBP. Give to open the LAD and RCA. After this palmar treatment, left ventricular aneurysm 1 year later, we gave this patient palmar treat. This ultrasound change. This patient follow up 10 years to publish the SI journal. This patient in our hospital to recept the sour to replace the valve, and about 2 years to left main the stenosis very serious. Our colleague put a stent to send to the aortic root and left main 1 stent, but unlucky. This patient second year still the stenosis very serious. We gave to OCT and iris to detect, and we put the another stent, put the middle this stent, and poke this left main. So this final result we give iris and OCT to detect this final results. After this patient 10 years follow up. For already the first stent to become the very total, we put the stent in the middle stent. So we suggest a new rescue model, the PIRR was a proposal for the acute myocardial infarction with cardiogenic shock and pulmonary edema for the first time. Just now, Professor Tu said. To this use a pacemaker, IBP, impeller, or ECMO. But I think respiratory support is very important. And the last is very important, revascularization. If we haven't last, maybe this kind of patient, the mortality very, very high. So this patient can rest 1.5 hours. We use MCPI plus 50 minutes CPI, and this patient only the half the vessel work. We put a stent to RCA, defibrillation, and to ICU the 2 week. This 1 year follow up. The left still occlusion. This we deal with this 2 stent. We another stent, the third stent gave us this. The 2 years later, the patient recover 42. This Anzhen Hospital, the teamwork crucial. Thank you very much.